Good evening, everyone. My name is Chris O'Flaherty, and on behalf of Oculus, I'd like to thank you for joining us for tonight's webinar titled Dry Eye Worth the Effort. Before we get started, I'd like to point out that you have a text box on the right side of your screen for asking questions. Please ask questions during the webinar, and we should have time for a short Q&A session following the presentation. Our speaker tonight is Dr. Penny Asbell. Dr. Asbell is professor of ophthalmology at the Mount Sinai School of Medicine, and she's director of their Cornea and Refractive Surgery Center. Dr. Asbell has published over 200 peer-reviewed articles, lectured worldwide, and appeared on several national broadcasts including CBS News, Good Morning America, and CNN. Dr. Asbell's various areas of interest include corneal infection, corneal transplant, cross-linking, refractive surgery, and dry eye disease. Dr. Asbell is also the recipient of several awards, including the National Research Service Award and the American Academy of Ophthalmology's Senior Honor Award. So without further delay, please join me in welcoming Dr. Penny Asbell.
Some of the things. This is some of the prevalence data from insurance, which makes it sound like maybe 5 million people is not a lot in the United States. But on the other hand, depending on how you look at it, maybe as many as a third of our population has some sort of dry eye kind of complaint. So the Dry Eye Workshop, which is reconvening as it turns out this year, but back in 2007, myself and others who participated looked together at a whole bunch of issues related to dry eye disease and came up with this definition. And that is that dry eye is multifactorial. It involves tears in the ocular surface. It involves symptoms of discomfort, visual change, tear instability, damage to the ocular surface, and typically is accompanied by increased osmolarity and inflammation of the ocular surface. So probably many of you have heard that definition before. But I think the thing to remember is when you look at any of the epidemiological data, and that's what's shown in this slide, these are studies from the United States, from Asia, from Australia, different parts of the world, all of them show that dry eyes, the prevalence increases with increasing age. And if you look at that same data, male versus female, it's still a preponderance of females, but you also see dry eyes in men as well. And we have to keep that in mind, particularly when we're seeing patients. We see men and women, of course, that either one of them may be having significant dry eye symptoms and signs. So it's probably, from a patient's point of view, the most common reason they show up. Aging, they may be from glaucoma. Diabetics have 2 times the incidence of dry eyes compared to non-diabetics. We know our post-LASIK patients, more than half of them, even 6 months later, complain of some dry eye symptoms. Our contact lens wearers, it's key for maintaining happiness, if you will, with contact lenses, and there's a whole slew of systemic medications that can cause dry eye. I think it's important to understand, as this study did in the Boston area, looking at the impact on daily activities. And you can see in this slide from that study, they looked at everyday activities, reading, professional work, computer, TV watching, driving during the day and night, and in each of those important activities, the likelihood of being symptomatic was much higher in the dry eye population than in those who were normal. So these are the everyday things that they're complaining about, and from their point of view, these are important. This is what we all do. We all do these activities, and if somehow we're not doing them as comfortably or as good a vision as we want, we're not happy. And that's what your dry eye patients are thinking about. This is one of the quality of life utility studies, which is kind of a weird study from my point of view. What they do is they say, if you could get rid of this problem, how many years, if you will, would you give up to get rid of the problem, years of your life? And the odd thing about looking at these utility studies is that those with severe dry eyes actually felt more strongly about it, would give up more time than either moderate to severe angina. So, and the mild dry eyes also would give up some time. So from their point of view, this is important. One of the ways I think about it is it's a little bit like back pain, and I tell patients that. You know, when you look at somebody with back pain, they look normal. They're not dying. They can actually look pretty normal, but you know they're not happy. And if any of them are yourself or your friends or relatives, you know that that's a chronic problem that they're not happy about. This is a study from Bill Trattler from Miami and co-workers who did a study called FACO, looking at consecutive patients who were going to have cataract surgery. So they looked at every single patient, and what you see if you're looking at corneal staining or Schirmer's score, a lot of them have abnormalities, even if you're not really honing in on that problem. In fact, when they look at the level of dry eyes measured by the DEWS sort of scoring method, where 0 is normal and 4 is severe dry eyes, about 3/4 of them had moderate to severe either signs or symptoms or both of dry eye disease. And cataract's still one of the most common, if not important, surgeries that many of us do, and it really does impact it. Try getting keratometry readings if the corneal surface is not good. And you may end up with the wrong IOL, the wrong axis for a toric IOL, or potentially even the wrong power. So it ends up affecting the satisfaction for our most important surgical group. Glaucoma. These are whole different studies, each different researcher, a different population. And what you find is that nearly half of the patients have significant findings typical of ocular surface disease. A lot of it is related to the drops. Most of them are BAK preserved, as shown in this slide. And the more BAK, the more likelihood they're going to have ocular surface disease and actually associated with poor quality of life. And frankly, it may lead to poor compliance. They'll take the drops the day before they show up in your office, but once they're at home, if the drops burn and sting and affect their quality of vision, they may stop them. So what do you find, whether you're looking at signs or symptoms, or as in this slide from a study by you and all on the treatment cost, it's significant. So if you do medical treatment, dry eyes is actually kind of cheap. The current budget estimates are about $3.8 billion, which is kind of cheap for medical care in general. But if you add in the productivity costs, we're looking at over $55 billion per year in reduced productivity. And what does that mean from a patient point of view? They're not doing as much work as they would like to. And if you look at vision changes in dry eyes, they're not blinking all day, and their vision actually degrades. It's a little bit like a dirty windshield if you don't have that window wiper on all the time. In between, the quality of vision goes way down, and that's how they feel. The vision goes way down as they open their eyes, and that's why they're not happy, and they tell you, I can't see, even though in the exam lane they may very well get 20/20. So when I think about the global features of dry eye, regardless of how they got there, whether it's glaucoma, whether it's post-LASIK, the tear film isn't very stable. The ocular surface usually shows some changes. It's a chronic pain syndrome, and that's what I think we should be thinking about it. And I talked about that visual degradation that they have, which is key for them doing their normal activities. So dry eye impacts everything: quality of life, cataract patients, refractive patients, and our glaucoma patients, just about all of them, is just common. And it's for that reason that I think it's definitely worth the effort. And actually, we all want our patients to be happy. The happier they are, the easier it is to see them and take care of them. And obviously, it's more likely that they'll be coming back to see you and recommending their friends and neighbors. It's certainly a more common problem as the population is graying. We talked about and demonstrated with studies the effect on quality of life, productivity, surgical outcomes, and patient satisfaction. So maybe it's not sight-threatening, it's not macular degeneration, but dry eye matters. It certainly matters to our patients. So one of the other issues is, how do you diagnose it? And a lot of people say, I don't know, I can't tell. I'm not sure, I just can't tell. And one of the problems is when you look at these, this is from the DEWS publication, this is from another study, I think, it gets complicated looking at these complex pictures. Nobody, including myself, is going to be going through all the potential ways somebody becomes dry eye in a normal office visit when it takes a lot of time. And we talk about aqueous deficient versus evaporative. Well, how do you tell? I mean, that itself isn't all that easy to tell, and in fact may be coexisting in a particular patient. I'm going to skip that slide. So One of the things that I myself in my laboratory and clinical trials has been looking for ways that can better monitor and diagnose ocular surface disease. We use symptom questionnaires. We look at tear quality. We look at vital dyes like fluorescein and lissamine. We look for lid disease. But basically what we're looking for is something a little bit more secure, if you will, than all of these picture show, which are very much dependent on the individual looking at the picture, the patient's response. Visual performance obviously depends on the patient. And we're looking for objective metrics that will better define this disease. And that's where, frankly, keratograph comes in. Many of us have stopped doing Schirmers, knowing it's so variable. Certainly it's an easy test to do, and therefore it's maybe reasonable to include, but we know it has many potential confounding influences like tearing, did you use drops or not use drops, etc., and it's really not that always helpful in determining dry eyes. So, and that's why, to be honest, I got interested in keratograph. I didn't mention at the beginning, but I've occasionally been compensated for speaking related to keratograph, a minor amount, but I got very interested in this device when I first heard about it, that it provided imaging related to dry eye disease and objective metrics that were not dependent, here's my conflict of interest, that were not dependent on either the patient or myself determining it. It's like judging height. We don't want to just say, hey, that guy's tall. We like to know his exact height, and we can measure that. And that's what we need with dry eye diseases. Once again, knowing that the diagnostic tests that we typically use can be influenced by many things, from the drops we use, the amount of stain we put in, reflex tearing, and the amount of time we take to evaluate it. So I did want to put in something about MGD, and I'll put a little bit more into that when we talk about keratograph, but I think that's an important part of looking at dry eyes, since it's now estimated that maybe 3/4 of dry eye patients have significant meibomian gland dysfunction, which might be contributing to it. So let's move on to looking at the keratograph itself, which is the reason you guys, which I thank you for doing so, joined in the call today. First of all, it's non-invasive and it's objective, meaning it doesn't depend on me, it doesn't depend on my tech, and it doesn't depend on the patient. It measures a variety of endpoints that may be important for ocular surface disease. The amount of redness, bulbar hyperemia. As you probably know, a lot of dry eye patients complain of red eyes, and that their neighbors and friends and other people they work with complain that their eyes are always red. It gives you a tear breakup time. It gives you a tear meniscus height, TMH. It looks at meibomian gland dropout. It looks at the lipid layer. It looks at tear film dynamics. This is still a very short examination. So the first thing you do with keratograph, that's the first test you do. You do that before you test vision, before you put drops in. I put that at the beginning of my list of things that I'm asking the technician to do. And they go ahead. The hyperemia is really a neat program. Again, I have no vested interest in the program, but it tries to draw out the normal vasculature that we see in the conjunctiva, and again document the amount of redness and even score it for you. So you can get a number grading on redness, which you can share with the patient and you can follow over time. And this is just a little bit of the computer program that takes out some of the vessels and enhances them. You can see actually the topography up here where we're looking. We're gonna see in a moment that we use that for tear breakup time as well. So it gives you a score. Again, your technician can do that, and you can look at the information. This is a non-invasive breakup time. So we have put no fluorescein in, no drops. It uses infrared light, which is good because it's not a bright light. It will not significantly provide reflex tearing from just being approached by the light. And what it does is look at the map here and look to see when it breaks up. So it gives you a couple of things. One, when it first starts breaking up on the graphic here, you can begin to see it here. And then you see over time what happens, and you can look at the rate of change as well. Not only the initial breakup, but the rate of change. One thing to be aware, however, is that the non-invasive breakup time is not one-to-one equivalent to the tear breakup time that you may do in measuring a patient. because here we have no fluorescein. We're looking at the breakup of the image, if you will, reflected off the corneal surface. And so it's a slightly different way of looking at breakup time. And you have to realize it's not going to be totally equivalent to your number with fluorescein. This is some of the data that's been done on breakup time just to demonstrate its repeatability and validity. I personally think we could use some more data, but at least we have a start on understanding how it works. And this is just a statistical analysis, shows the authors in Cornea from 2012, suggesting that the tear breakup time is an accurate measurement of the change in the ocular surface. This is looking at tear meniscus height. What you look at here is a tear film layered on the bottom of the lower lid, and they have a little ruler. I generally measure along 3 spots, one right below the pupil down here, and one sort of 3 o'clock down, a straight line down, and 9 o'clock. And I average those 3 together. Again, you're using an infrared light, so the light is dim and less likely to cause tear stimulation from a bright light like we normally do when we're looking at a slit lamp examination, and we can get a tear meniscus height. And this, again, is a study done by a couple of co-workers and presented at the Academy in 2012 with a reference at the bottom and 100 subjects, suggesting that the tear meniscus height was repeatable and that it was an accurate way of assessing tear volume in these particular patients. This is one of the studies I think we did on red eyes, showing that actually there was more internal repeatability with the machine versus either the patient's judgment of red eyes or the clinician's. And I think I have another one here just showing it's just a statistical analysis suggesting that we get repeatability with the machine, the keratograph, that's actually more I think, acceptable, if you will, than either the clinician or the patient judgment of the red eye. And again, you can change that over time. This is another interesting way of looking at tear film. I haven't explored it that much, but I think it would be worthwhile. This is like when you get sunlight coming into the room in a sunny day, and you can see the dust particles floating around in the air. This is looking at tear dynamics by looking at the tiny particles that exist in everybody's tear film, kind of like the dust. And you can look at the movement and get some feel for viscosity. A thick tear film, those little floating around pieces of whatever, are going to move very slowly. If it's a more liquid or tear film, they'll move more quickly. I don't believe there's a measurement related to this, but it's a way of analyzing the tears. Another thing is a tear, looking at the tear lipid layer, which we know is important. Most likely, its main function is to decrease evaporation. This is looking, if you look closely here, you can see color changes over the topography. That's related to the thickness of the lipid layer. And you can look at that as well with a keratograph and get some idea of the quality of the lipid layer. I'll see if this works, but you can see as the patient blinks, there are changes in these colors which tell you a little bit about the lipid layer. Now, I don't know if keratograph has worked on actually coming up with numbers. I'd like to see that, but at least you can get a gestalt, a feeling about the lipid layer as they're looking at them and as they blink, as this video does in this patient, and get a feel for the amount of lipid and the change thereafter. Okay. This is really neat. I just want to make sure I'm on the right one here. Yeah, the mammography. So we've been talking about meibomian glands being a significant part of dry eye disease. And when you look at these pictures, again taken with infrared, this is pretty normal looking meibomian glands. Here they're a little irregular, and frankly in this one they're not only tortuous, but there's areas where they're absolutely dropping out. And these are, again, pictures taken straight from the keratograph, okay? They're easy to do. The one thing that's a little bit hard is looking at the upper tarsus. You've got to flip it to get a good look. And that can be, depending on your technician and the patient, a little bit more demanding. I generally ask them to look at the lower lids and then grade it. There's a couple of grading scales available for looking at that. I think with time we're going to get more automated measurements about dropout, like is shown here, where you could say where the meibomian glands are present and where they're dropped out, and again come with a numerical score defining the amount of meibomian dropout. And this is, again, a clinical trial that's been published looking at mammography to understand how it correlates with OSDI, a symptom score, suggesting that it's a good indicator of meibomian gland dysfunction and the problem they're having. So I'm going to kind of, I think I have a few more slides and almost going to tie it up and take some questions if you'd like. This is a 51-year-old male who had seen everybody under the sun, maybe some of you. He actually was from Canada and had been complaining of grittiness, burning, and pain for several years. He had a very high OSDI score. It goes up to 100. His was 70, almost 73. He had good vision, your typical dry eye patient. He looked like he had meibomian gland dysfunction and did not seem to have a lot of secretions even with pressure on the lid. He had corneal and conjunctival staining. He had a Schirmer's that was looked almost normal, and they were sort of, in that range, 9 to 10. And his breakup time seemed sort of short, perhaps. But take a look at this keratograph on the meibomian glands. You can see here that this looks actually pretty normal, but this upper lid, he has a huge amount of dropout. Another thing on the tear breakup on him, look how early it starts, very quickly. And then it has a steep curve going up showing that it continues to break up very quickly. So his tear breakup time was 2.17 seconds, very short. What's interesting, however, is tear meniscus height is 0.5, which is considered normal. So maybe we'll finally be able to separate the aqueous deficient tear film patients versus the evaporative, as in this patient, which may also impact how we treat the patient. In fact, something like restasis might not be all that helpful in this patient, given that his problem is more the meibomian gland, and we need some attention on that. On the other hand, on the other eye, these meibomian glands in tortuosity, not too bad. His tear breakup time was much longer, almost in the normal range, but his meniscus was a little low. So in this eye, he actually had a slightly different picture that better correlated with the findings in that eye. So I think not only are we going to have, as in this picture shows you, documentation of what happens. And what they do is they take the picture, it looks kind of like this, which is interesting and pretty nice, but then it enhances it with a computer so you can very easily see the meibomian glands. And it's a great way to show patients why you think they should take care of the meibomian glands. Maybe, depending on your choice of approach, warm soaps, lid scrubs, maybe other treatment modalities, expressing the glands, etc., that might be helpful. But understanding the problem is often half the battle to make the patient on the same side as you in terms of what to do about it. So I'm really kind of excited about keratograph, frankly, and that's why I'm taking the time to speak with you today, and that's why you're joining me. It is not invasive. You use no drops. You touch the eye only to pull down the lid. It's objective. It gives you numbers. It gives you pictures. It looks at structural abnormalities like meibomian gland dropout. It looks at functional abnormalities like tear breakup time, the lipid layer, tear meniscus height. It looks at signs of inflammation, the bulbar redness, and it provides documentation which you can put into your medical record. You can look at changes over time. You can use it as endpoints in clinical trials if that's something you do. And you can share this data with patients, which is key. So I can have them look at it and talk about it. I love the non-invasive. I think it more clearly evaluates some of the problems we commonly see in dry eyes, far more than some of the tests we do in the office. And I do a lot of dry eye work. I still do those, but I find these extremely helpful to document more clearly what's going on with that patient and what I can compare in future visits. So I think I'm very happy that they've developed it, frankly. I think it was a great idea. It wasn't my idea, but it was their idea. And it is easy to use, and I do enjoy using it. I did want to mention to you, for those who like to publish, that I'm involved in 2 journals at the moment, BMC Open Access Ophthalmology, which means once you publish an article there, it's online immediately, worldwide access, and Eye and Contact Lens, which is a journal of Pleo, where we look at corneal topics, including dry eye, which is a peer-reviewed journal There's no charge for publishing in that journal. For 2 opportunities, if you're doing any publishing, I'd be happy to consider any of your publications. So that is kind of what I wanted to cover. As I said, I think you'll really like the Keratograph. I think we have seen that in almost all of our ophthalmology care, that documentation, whether it's OCT of the optic nerve, OCT of the macula, other slit lamp photography, we've seen that the documentation helps us in just remembering what we saw and what we need to follow over time. But equally important is that it gives us access to communicating with the patient in ways that are, as they say, a picture is worth 1,000 words, in ways much better than just explaining it to the patient verbally, and often they don't know what you're talking about. They see the picture, they see those meibomian glands look abnormal, they see a low tear meniscus height. You can show them that graph where their tear film is breaking up, and they understand. That doesn't always mean we can correct it, but at least they understand what the issue is and how best to address it and follow it over time. So I think it's a neat tool, and I think we'll see increasing opportunities to use it to help us diagnose and follow patients more easily over time. So thank you for joining me. I think it's possible to take some questions. If it is, we'll open it up for questions. But I thank you for, one, being patient. I apologize for a little delayed start, and helping us work through some of the kinks in the computer system. You can see my email here on this last slide. Feel free to be in touch with me at any time for any questions, comments, or help if you're using it, or any other kind of question. I do get a lot of email, but I'm happy to answer to any of your comments or questions. So thanks so much for joining us. Have a great evening, and if there are any questions, I'll take them. I don't know if the system is set up for questions.
Yes, actually, Dr. Asbell, we are set up for questions, and thank you very much for that presentation. Just to let everybody know, I did mention it early on, but you do have a text box on the right side of your screen for asking questions. If you put that in, then I can pass these along to Dr. Asbell. We do have a couple in the pipeline right now, if that's okay.
That sounds good. Am I going to see them?
No,
Okay.
I can only see them as an organizer.
Okay.
That's
So
okay.
go. Can you read them out to us?
So one of the questions that I just have here is, do you use a dry questionnaire? If so, which one? And a second part of this question is, which metric do you feel most closely correlates with patient symptoms?
Both great questions. So for a questionnaire, what I'm doing now is you can download actually Allergan produced at the OSDI. That's probably the most validated questionnaire for dry disease. We could argue whether it completely covers the topic, but it's 12 easy questions. It's available online, and you're allowed to use it in your office for no charge. So what I have been doing to make the office flow as easily as possible, I give it to every patient. So to be honest, some of the patients are not really dry eye patients. It could be keratoconus, it could be whatever, but I give it to everybody. That way nobody has to think. And then I don't even add it up. There's a way of adding it up and getting a score, etc. I just look. Are they mainly zeros? Well, they're probably not bothered too much by dry eyes. But if I'm seeing a lot of 3s and 4s out of those 12 questions, that's somebody I'm going to investigate a little bit more about what's going on with their ocular surface, why they're so symptomatic. So I find it an easy, quick tool that doesn't take up time. They're doing it while they're waiting to be called in to be seen. In terms of what best correlates with dry eyes, if I'm doing just standard stuff, so not the Keratograph, I actually think the lissamine green on the conjunctiva is probably the best correlation. And I use in my general office exam lissamine strips that come just like fluorescein strips, and I kind of moisten them, put a lot in. It's not like taking an IOP. You want a lot of lissamine. I actually put it in before I do the dilated exam if you're already dilated. So it has I try to wait a minute or two before I evaluate conjunctival staining. In terms of the Keratograph, I like it all. I'm looking at the tear breakup time, when does it start, and what does that graph look like, and I'm looking at the tear meniscus height, and I'm looking at the meibomian glands. Those 3 things are my go-to for the Keratograph. The tear breakup time, the tear meniscus height, and looking at the meibomian glands themselves. And I'm using those together to kind of get a feel what's happening in that particular eye, that particular patient. Any other questions?
I just have a couple more so far. Um, do you have any basic guidelines as far as your treatment for given types of dry eye?
Good question again, how to treat them. First, for full disclosure here, some of you may know, I'm currently running with lots of coworkers, some of you may be on the phone, colleagues, on a dry eye clinical trial funded by NIH called the DREAM Trial, Dry Eye Assessment and Management. And we're specifically looking at omega-3. Now, a lot of you may be convinced that it works. When you look at all the data, maybe it works, maybe it doesn't. We hope to have a more definitive answer for you perhaps next year as the study continues to roll on. And in that, we're looking at some of the other options in terms of treatment as well. So I think that at this point in time for dry eye disease, you need to try a stepwise approach. We have not gotten to the point where we can personalize it, which is what we hope to do by using diagnostic tests like keratograph, hone in on what that specific patient needs to best address their problem. And we haven't gotten there. So it is still at this point a little trial and error, trying one thing, then another thing, and going from there to see how they work. So that is a frustration. But I think telling a patient that this is what we're going to do is very helpful. I don't usually start a lot of things at one time because then I don't know which of them should continue and which could be dropped. So I try to do it a stepwise. I try to, am I going to go to unit dose tears as my first step? I don't particularly add unit dose tears and something like Restasis at the same time because I don't know if the patient's really going to need both of those. They may just do terrifically with a unit dose tear. What you may find is a lot of patients say, hey, I use tears all the time and they don't work. And then I said, well, what do you use? And it goes back to a little lecture I once gave in Europe on dry eye disease. And we had a slit lamp set up to a video to demonstrate ocular surface disease. And I'm thinking, well, where am I going to get a dry eye patient? You know, this isn't the clinic or anything. And I said, gee, can I take a volunteer? I'll kind of give it a try. And somebody in the first row waved their hand and came running up and said, yeah, you could look at me, you know, kind of thing. And as I was setting up the slit lamp before I turned on my speaker, she listened and said, you know, my eyes really bother me. And then I put in the fluorescein and listening, and the eye lit up like, you know, as we say, a Christmas tree. And it turned out what she was doing is she was using over-the-counter a tear supplement, not, you know, one of the ones that we generally go to. And because her eyes were so irritated, she was adding more. So she was using 15 to 20 times a day a BAK preserved artificial tear. If you do that in a mouse eye, not that we're going to do that together, but if you do it a BAK preserved drop in a mouse eye twice a day, the cornea perforates. I mean, that's how irritating it can be to the ocular surface. And this poor patient, with a plane trip and everything else that dries the eyes, was using drops 15 times or more a day. So you'd be surprised that some of your patients will be doing stuff that you don't even know about. Don't forget to ask, because they may think, oh, it's over the counter, I don't have to tell you about it. You know, so definitely ask to make sure you're not getting perplexed because they're doing something that's exacerbating their dry eyes. Any other questions?
I just have one last one here, and to be honest, I feel free not to answer this one, but it's a question on the Keratograph 5. What test do you bill for with the Keratograph 5M?
Okay. I think I'm not a billing expert, but I believe you. I don't know if you are, Chris. If you know better answer billing questions. This is made by Oculus's machine, which some of you are familiar with, the Pentacam machine, which is one of their other machines that are very popular. Do they supply a call-in line or anything for billing questions or anything like that?
So, I mean, what we have is we have a reimbursement guideline that we can supply upon request. We're certainly not billing and coding experts either, but we do have a a reimbursement guideline that was developed by a Corcoran consulting group. And
A copy.
yeah,
Yeah. Okay. So And can you share, if somebody here wants to contact you, would you be
Yeah,
able to
I can
share that with
absolutely
them?
share that with anybody that wants that, and then
How would they
it will
get a
cover.
hold of you? Do they
So
have your?
actually, I'll go ahead here if you don't mind. I have this last slide
Oh,
here.
great. Thank you. Does that go to you or it goes to the general mailbox?
So this will go to the general sales mailbox, but it will get forwarded to the appropriate personnel. So for any questions or comments, whether it's for reimbursement, general questions on the Keratograph 5 or any other Oculus instrument, you can email us at sales@oculususa.com. And then on our website, you can view any webinars or register for future webinars. So if for any reason you missed part of this one, or if you want to get in on some future webinars, then you can go to this website right here.
So I have to tell you, I think that, thank you for joining me. Thank you, Oculus, for setting this up. I think they do a very good job of trying to have web seminars on their equipment. And they, using German technology and concern about detail, I think they have been very good about making their instruments and trying to provide good data on its usefulness. So I compliment them on that. Again, I have no financial interest in this company, but I don't even know if it's publicly traded or whatever. I
Well,
don't know anything about that.
thank you
But
very
at
much,
any rate,
and
it's a
on
good help.
behalf of Oculus, thank you for not only your kind words, but for uh, uh, doing the presentation. It was a
Yeah, I
lot of
forgot to
useful
tell everybody
information.
that I'm wearing a walking boot. So I had to run over from the other building with my walking boot, a little extra from a visit to Istanbul where I missed a step and injured my foot. Anyway, so thank you for bearing with us as we got started this evening, and look forward to hearing from any of you if you have any questions or comments. And thanks, Oculus and Chris, for setting up this evening.
Thank you. You have a good night, Dr. Asbell, and everyone out there. Have a good night.
Thank you very much.